I would say that it's somewhat appropriate that the surgery talk is last because most patients and physicians think of surgery as a last resort. And hopefully I will convince you that in fact the surgery talk, if not first, should certainly not be last. So I'm going to try over the next 20 minutes, and maybe could you tell me when we're getting close, to talk about why epilepsy surgery makes sense for a lot of patients, when we should consider surgery, and then of the surgical options that are out there, what type of surgery for what type of situation. So I'm going to have to go over some things a little bit abbreviated because we could spend an entire weekend talking about just this one topic, but let's go ahead. So I have no financial disclosures relative to this talk whatsoever. This is just all the colleagues that I work with, either at my institution or other places. Epilepsy is a team sport. You don't get surgery unless you've gone through experts like you've heard in the room today as neurologists and neuropsychologists who actually all agree that you're a good surgical candidate and talk about the risks and benefits. And so it really is a team group. And also colleagues who have helped with some of the thoughts on this talk. So I don't really have to go through again why patients with epilepsy should consider surgery because Professor Baker made that perfectly clear in talking about the neuropsychological consequences of epilepsy. You know, living with uncontrolled epilepsy is very bad. It's very bad for a lot of reasons. Everybody, I'm sure, has talked about them several times tonight, but risk of death, loss of driving, higher rates of depression, suicide, other medical codependencies, medications. I mean, all of these sorts of things impact life if epilepsy is not controlled. So why else should patients consider surgery? Well, because surgery actually works. It works really well for many forms of epilepsy. So if you look at, depending on the type of epilepsy, and we'll talk a little more about some of these, do we have a pointer, do you know, or no? Okay, so the top bar is for temporal lobectomy, which is one of the most common types of epilepsy surgery. And that what this graph shows is what's the percentages of seizure freedom with that surgery. And it's better than 70% chance of seizure freedom with temporal lobectomy. It's better than 70% if there's an MRI lesion on the brain responsible for the epilepsy. In the temporal lobe, if it's not lesional, it's still better than 50 to 60%. And other parts of the brain we need to explore in more detail and more carefully. So despite this, people estimate that anywhere from 3 to 5% of potential epilepsy surgery patients ever actually get referred even for an evaluation. And a lot of that is because, first off, the people who refer to the epilepsy neurologists oftentimes think that surgery is either too dangerous or too much of a last step, or maybe we should try more medications. And similarly, patients themselves are petrified of surgery. And it makes sense. I've never met a patient in my career who wasn't psychotic who wanted brain surgery. Nobody walks into my office and says, gee, I can't wait, you know? But the whole point is to get to a point where we say, okay, this is why we're doing it. This is the potential risk. This is the potential benefit. And how do we stack that in terms of benefit and minimize risk? And these are just a couple of papers talking about, 60% of patients think that surgery is very dangerous or moderately dangerous. Over 50% of patients, if they were told in this one urban group, if they were told surgery is going to cure your epilepsy and you're not going to have a problem with surgery, over 50% said no. Despite all the risks, despite all the potential problems. So this is what we're dealing with. How do we make epilepsy surgery more appealing to patients and families? And one of the big trends in the field is trying to make it less invasive and safer and more effective depending on the exact subtype of epilepsy. So the ILAE met a few years ago and over the course of a period of time went through all of the world's literature. And the reason why we say that people should be referred for epilepsy surgery if they've failed 2 medications is because the chance the 3rd, 4th, 5th, 6th, 7th to 10th is going to work is exceedingly low. So if somebody is healthy enough to consider epilepsy surgery and they've failed 2 medications, there's no point waiting any longer. The average time a person has epilepsy before they get a surgery referral is 20 years in the United States. Even when there was a study to try to push it back, That study got closed because patients couldn't get enrolled quickly enough within the 3-year window, even when everybody in that patient's care was trying to do so. And so it really takes a concerted effort to get patients in for surgery. And even older patients who are healthy, or even patients who are seizure-free but have an MRI with a lesion that's clearly causing epilepsy, oftentimes that patient could potentially be cured of that lesion and off medication if the surgery is simple and safe. So it really depends on the individual details of any particular situation. So if you are referred for epilepsy surgery, that doesn't mean you're even going to see a surgeon. It means you're going to see a neurologist, your epilepsy neurologist, to talk about surgery and to go through this very detailed evaluation. Going over your history, your physical exam, your EEG, probably recording seizures in a lot of circumstances, your brain MRI, your neuropsychological testing, as Professor Baker was talking about, and then a whole team of people. All those people get together and look at your case, and it takes us about an hour a case with about 20 people in the room, with everybody fine-picking every little detail to say, okay, what's the right thing to do here? And once in a while, we have a situation like this MRI where you see this is actually the temporal lobe here right behind the eye. And this is what's called a low-grade epilepsy-associated tumor. And we see that on an MRI. And maybe it was missed and it was smaller a little bit before. But something like this we look at, we say this is a home run. Because this patient's likely going to be seizure-free, not have deficits at the end of this. But a lot of times the MRI is negative, and then it's a lot more work for us. So that's where imaging and pathology comes in. And without going through all this, the top bars are basically the chances of seizure freedom at 1, 2, and 5 years, depending on pathology. And usually from the MRI, we actually know what the pathology is likely to be. So we can predict for a patient, a family, what's the likelihood in your situation that we're going to make you seizure-free, and what's it going to take to get there, and what's the risk going to be? Because that's all surgery is. It's balancing risk and benefit. So after that phase 1 evaluation, there's 2 fundamental questions. Have we found where we think the epilepsy is coming from, which side of the brain, and where exactly in the brain? And what functions do we think might or might not be at risk in those areas of the brain? If we know where the epilepsy is coming from, and we think it's a safe area for us to operate, we don't need to do anything else. But if we don't know those questions, if they're not answered adequately, then sometimes we have to actually explore in the brain to answer those questions because we can't learn from the outside. We've done every test we have, and we still can't tell. And so there's 2 ways this is done, and this is the only brain picture I'm going to show, and I hope it doesn't make anybody uncomfortable. On the left is a picture of a human brain with this 2-dimensional set of electrodes sitting on the brain. This is how throughout most of my career, I've been doing this for 25 years, until the last 10 years in the US, most of Western Europe, outside of France and Italy, people monitor the brain to find out where seizures are coming from. As you can see, that requires a big opening. That's a big operation just to get information. And I will very fairly tell you in all honesty, it's my least favorite operation in all of neurosurgery of everything that I do. Because we're doing a big surgery where we're just getting diagnostic information. On the right are what's called stereo EEG or SEEG electrodes. This is technology that was really developed between France and Italy over quite a long period of time. But in the last 10 to 20 years, as we've gotten better and better brain imaging and we've gotten surgical robots and other tools, it's become, to everybody else, now obvious that they were right, that this is much less invasive now that we have much safer ways to do it. And so what you see here, each one of these little white caps is a cap on a tiny electrode. The electrode's under 2 millimeters in size that's going through a 2-millimeter hole in the skull to record the brain's activity without having to do a big surgery and open everything up. And so what happens now with this is we have, as I said, we have surgical robots. There's one here in town that are used ahead of time by the epilepsy neurologists and the surgeons to plan out exactly what areas in the brain do we need to look at to determine where the seizures are coming from based on the patient's individual history. What does their seizure look like? What's the behavior of the seizure? What's the MRI? All of that information is put together with the EEG, and we come up with hypotheses. Hypothesis 1 is we think it's here. Hypothesis 2 is here. Hypothesis 3 is here. And we put in enough electrodes to answer all those hypotheses. And we end up with a 3-dimensional model of the brain like you can see on the lower right. and where we've got the electrodes actually going into the brain, through the brain. They're so small that they don't actually cause any sort of functional damage to the brain. The risk of bleeding or infection is under 1% with this procedure. It's a surgery. It's obviously a brain surgery. It's general anesthesia. It's a big deal, but it's much less of a big deal than what we used to do before to try to answer these questions. So what happens because of this is that we actually have a lot of advantages. And without going too much of the detail, if we're not sure which side of the brain, we can put electrodes on both sides and answer the question. If we find that we're close, but we're not at exactly the right spot, we can just go back and add a few more electrodes and finish the evaluation at the same hospitalization. And because it's so much less of an operation and a safer operation, a lot more people are actually willing to undergo that procedure to try to figure out where's their epilepsy coming from. And so I'm going to show you an example case here. This is a little bit of an unusual case, but we see all kinds. And unusual in that this patient didn't actually develop seizures until fairly late in life. Oftentimes seizures will come late teens, early 20s for people with some kinds of subtle types of brain malformations. This patient was actually late 20s, super high functioning, like super high IQ, accomplished professional, but developed seizures, and because of that was really changing their life to the degree that they weren't comfortable starting a family on multiple medications. So still working, but a much different life. And so when we evaluated all this, the MRI actually didn't tell us anything. There's a little benign cyst here. It's got that, I could point it out, but for people over there. So I talk loudly. So this is actually what we're looking at. We're looking at the temporal lobe, which is right here. Can everybody hear me? Yeah, so this is the temporal lobe here on actually, this is the right side of the picture, is left side of the MRI. This is the hippocampus where often seizures come from. The hippocampi are symmetric, they're normal. There's nothing on this MRI that tells us where her temporal lobe seizures are coming from. So, and she's very high functioning. And I think that Professor Baker would probably agree, most of the data that we know about patients, what happens to them after surgery, is based on larger numbers of population-based studies. And this patient walked into my office about 10 years ago and said, you know, I don't want my cognitive abilities to get worse. I want you to find a way that you can try to stop my epilepsy without taking cognitive risk to any significant degree. And most people would say the standard answer surgically would be, oh, it's right side of the brain, she's left language, left memory in terms of verbal memory. You're probably not going to notice much. But that wasn't the question. The question was, am I going to be able to work as a highly competitive Wall Street executive still after you do a surgery in a part of my brain where the typical surgery is what's called a temporal lobectomy, which removes the majority of the temporal lobe. And we don't know in this particular patient how much of the temporal lobe's involved in her seizures. So, 15 years ago, we would have said, okay, we can put one of those big subdural grids in. We might have answered the question. Or we would have recommended an open surgery and said, you'll probably be okay. Probably a good chance we'll stop your seizures. Hopefully, we won't cause more cognitive problems. But now, she was actually one of our first patients who had stereo EEG electrodes put in now a decade ago. And everywhere else she went, because it was just starting in the US, people were like, that's crazy. Because of the fact that now every one of those sites would do the same thing probably in this patient, because technology is changing over time. And once we have that information, then we know what are our options, what's it going to take to stop her seizures, and what are the risks. So this is a temporal lobectomy. It's actually removing all of this pink part of the brain here is what's part of what's called a standard temporal lobectomy. That's a lot of brain unless you think all of it's necessary to remove. Now, it's the most effective treatment we have. It's been studied in multiple randomized clinical trials, which is the best piece of medical evidence we can get. And it's a very effective. It's much, much better than continuing on medications, which almost never works to stop seizures. But again, it requires a bigger operation as part of that. So in this case, this is actually this patient's electrodes that I showed you. And we found that the seizures were coming from a very focal spot at the front of the hippocampus. And so now we had choices. We could say, okay, we can do an open surgery, which there's a lot of ways we can get there that don't require taking out the whole temporal lobe. Or we said, we've actually got this new approach where we can put a laser in the brain, and we can use that laser to treat that area in an MRI scanner without opening your head whatsoever, and let's see if that works. And so this is a laser fiber. You can see that long dark thing that's going into the brain here. And so this is a laser fiber here going into the brain. This is the hippocampus. It comes from the back of the head, and it goes in. And in an MRI scanner with some physics tricks, every 3 seconds you can get a temperature map so you know exactly how much of the brain is being heated. So this patient, again, was an early laser ablation patient, and this is what it looks like. Just like when we're putting those electrodes in, we put it in this time through a 3mm opening in the skull. The laser fiber goes in, and we get this MRI readout like you see on the lower left there. And that's what the MRI looks like. That's the area that we treated. And so this is, if I can make this work here, so here's what it looks like sped up. So that's actually, we ablate an area, pull back, and we ablate again. And so that's how we treated her epilepsy. But we told her ahead of time that we don't know if this is going to be enough, because we're doing less here than we would do with an open surgery. We would remove more brain with an open surgery than we could treat with this. But we said, if it doesn't work, we can always go back and do the open surgery. At this point, we've never opened her head. We've put a bunch of little electrodes in, and then we put a laser in afterwards. And so what we find over time, and we meaning the epilepsy community, because we all contribute and help each other, is that not surprisingly, because we're not doing as much, laser ablation is not quite as good as open surgery. Some people walk in my office and they say, "Doc, you get one chance. I'm not coming back again." And I'll say, "Okay, open surgery, best chance." Other people are like, "If there's a chance you can keep me from having an open surgery, you get as many chances as you want." And a lot of people are in between somewhere. So it's not a right or wrong, it's a balance. It's what's best for an individual patient based on what the options are. Laser, because it's minimally invasive, it's much easier recovery, back to work much quicker, less pain, safer, etc. But again, not quite as effective. And we also now, people are using lasers for all types of epilepsy that I don't have to get into, but things called hypothalamic hamartomas, which cause a particular type of epilepsy. There may be somebody here who has that or has a family member with it. People sometimes even will do a laser for a part of a complicated situation, then do open surgery for the other part because it makes sense to combine them. And so sometimes we do it all together. And here's actually a paper that we wrote that's amazing. It's a 3-year-old paper, and it's almost obsolete because of how quickly the field's moving. But if anyone wants to take a look at it, it's easy to find, and it kind of outlines all the different things that we treat with laser ablation now. So what about in this same patient if the seizures came from the left side? If these same seizures came from the left side of the brain, it doesn't matter whether we did an open surgery or a laser ablation. If we removed that hippocampus, she would have lost substantial amounts of verbal memory. And again, Professor Baker could tell us more about it, but this is a significant deficit to a functional patient. So in that case, we would have had to find another option. And we have different options. This device on the left is an implant that goes into the skull. It's actually right now only available in the US. Whether it's going to spread or not depends on what happens with the company. But there's also deep brain stimulation, similar to what a lot of people have seen for Parkinson's disease, where electrodes get put in specific locations in the brain to try to interrupt the network of the epilepsy. Or you can put a vagus nerve stimulator on the neck. And all of these, to actually remarkably similar degrees, are effective in a significant proportion of patients with epilepsy. So we would have tried one of those things if not. And then finally, if somebody's too ill to undergo general anesthesia, we could consider focused radiation, which actually works quite well, but it takes anywhere 1 to 3 years to work. There can be some side effects, some radiation-induced swelling in about 30–40% of people that take a while to get treated. It's not our first choice, but actually it's another consideration. And then if we go back to that initial evaluation where we're trying to figure out, or even once we put electrodes in the brain, if we find that the seizures are generalized or widespread coming from multiple parts of the brain, then we're not going to be thinking about a focal treatment in the brain. We're going to be thinking about how can we interrupt that generalized network of epilepsy, and we're going to go back to one of these options between deep brain stimulation, vagus nerve responsive stimulation. That's kind of, the details are beyond the time we have here. So I want to just quickly, put a shout out to the home team here. I've actually known Professor O'Brien, the surgeon here. We met many years ago when I was at a meeting here. And just to let everybody here know, you guys have a great team in your backyard. They've got, if you look here, they've done a ton of epilepsy surgery over the last almost 20 years. They do, all forms of resection. They've got the robot and do SEEG monitoring now, intraoperative monitoring, and they're planning, and hopefully the government will come along with laser ablation. A very strong epilepsy neurology group, a very strong team of people. And also it's really important when you have a team like this that you're working with your basic scientists to try to learn more about epilepsy, and they're also really strong in that regard too. I mean, really some world-class publications, particularly in the area of what's called microRNAs, where they take small bits of tissue off of the electrodes when they come out and try to study the epilepsy to try to learn more about what's going on. So, that's pretty much a rapid overview of why, when, and what surgeries actually make sense. And so if anybody has any particular questions, I'd be happy to answer them. And if I get this right, is it Gurev Ma'agut?
Well, Gurev Ma'agut to you. Professor McKhann, thanks very much for, again, very clear, very succinct presentation covering a vast range of, again, we could have had you here for maybe 3 hours speaking on this. We do have a couple of questions, and we are just running short of time. I just say we have a few minutes left to the, if we could just get an extension for about maybe another 10 minutes, that'd be great. But one of the questions is whether surgery is an effective treatment for autoimmune related epilepsies. And it says probably not due to the etiology.
So most of the time not. Most of the time autoimmune epilepsies are treated by figuring out which subtype it is and how do you alter the immune system. I will say though that occasionally you find somebody who looks like, despite what should be a more generalized problem, they've been through every treatment that the neurologists have, and they still have a very focal epilepsy within that autoimmune phenotype, within that autoimmune status they are. And so if somebody has a purely focal epilepsy as a result of that, which sometimes happens, then it's just like some of the genetic epilepsies. We want to always figure out, is there a genetic epilepsy and is there something else to do before we do surgery? But again, if somebody still has a very focal epilepsy, we can identify that focality and we can figure out that it's safe. It doesn't mean that they're completely not a surgical candidate.
And second question is, what if epilepsy is on both sides of the brain? So I guess how would surgery, or what, I suppose, what options might you have?
So if it's truly bilateral epilepsy, the options are only going to be some form of neuromodulation where we're, again, putting electrodes somewhere deeper in the brain to try to interrupt the epilepsy network. But it's important to make sure it's bilateral. For instance, frontal lobe seizures can often spread incredibly quickly from one side to the other, and so sometimes a patient who you think might be bilateral is actually unilateral. Also, in temporal lobe epilepsy, like that case I showed, a lot of times if epilepsy goes uncontrolled for many, many years and decades, what was unilateral becomes bilateral. And so that's one of the reasons to actually treating people earlier in their epilepsy is more effective than waiting until the epilepsy is more severe.